Hi, everyone. Really excited to have another guest yet again in the VBC One Take studio. I'm really excited to interview this guest because I know that there's been a lot in the recent rules and a lot of changes around PAD screenings and a lot of the screenings that we're doing on our Medicare Advantage members and our ACO members. And so please help me in welcoming Chris Trygstad, who is VP of Product for Biomedix. Hey, Chris, how you doing today?
I'm good. Thanks for introducing me, Shannon.
Awesome. So glad to have you here today. I know we've got lots to talk about. Why don't we start off with talking about? I know that you guys frequent a lot of the conferences, and so folks have had the opportunity to get to meet you and John and Rachel and the rest of the team. But I'm pretty excited for a presentation that you have that's coming up at Rise West here in a couple of weeks. And I think it would be great to give those that are going to be with us in Colorado a little bit of a preview about what we could expect from you guys. And then also, too, for those that are maybe on the fence of deciding to go, or maybe those who just can't join us, but they would get the benefit of hearing from you what you're going to talk about.
Yeah, so it's a great question. Yeah, we will be at Rise West. One of the big things that we'll be talking about are changes with the V28 model and some changes that folks can make operationally. I know when V28 first came out, and we're still gradually transitioning to that full V28 model. What we've heard in the marketplace is peripheral artery disease no longer risk adjusts, and I think there's an opportunity for us to counter that objection. We've been in the market helping primary care doctors and other healthcare professionals identify peripheral artery disease. It's a deadly chronic condition that sometimes leads to amputations and is commonly associated with other atherosclerotic disease like coronary artery disease and things like that. So we think that screening for peripheral artery disease is still clinically valuable. I even think about we had a customer who they were screening all their patients for peripheral artery disease, and they found a patient that was asymptomatic. They referred them to a vascular specialist and not only found atherosclerotic disease in their legs, but they also found issues with their carotid artery. And they probably saved that patient from having a stroke. When we think about that plaque that builds up in the arteries of your legs, it can also build up around your heart. It can also build up around the vessels leading into your brain and other systems like that. Clinically, it can make sense. From a risk adjustment perspective, it still does make sense to screen for peripheral artery disease. When we look at the codes, asymptomatic peripheral artery disease no longer risk adjusts, but things to keep in mind are if a patient is experiencing rest pain in their legs, that it does risk adjust. And the RAF for that HCC code is actually higher than it currently is in the V24 model. Thinking about so if we think about screening, one of the things we're going to be talking about are number one, there's a phenomenon to underreport issues. If I'm a 65-year-old and it's starting to hurt when I walk, am I going to be likely to tell the doctor that? I know I'm probably guilty of underreporting any sort of issues that I have with my doctor because it's a devil you don't know. And that phenomenon has been documented in other clinical studies, even with pain while exercising, or what's commonly called intermittent claudication. There's been studies that have shown a common coping strategy is to just not exercise anymore. It hurts when I walk. I'm not going to walk anymore. So that atherosclerosis is going to continue to progress to that rest pain. We also worked with a nonprofit that does some PAD advocacy and found that oftentimes PAD is misdiagnosed. If you think about a doctor who is focused on maybe nerve pain or back issues, sometimes that pain in the legs gets diagnosed as maybe fibromyalgia or sciatica, or it gets chalked up to osteoarthritis. We've seen that PAD is one of those diseases that's underdiagnosed. Not a lot of people know about it. But that cardiovascular care doesn't stop at the belly button. Finding disease in the legs and ensure that there's a good quality of life is important.
I think you raise so many great points and would agree with you. I know you hear a lot of times, and I know even in my own family, older relatives complaining of pain in the legs and attributing it to getting older. And that's not necessarily. And then also, too, the point that you mentioned about not wanting to say things, also true. I was part of a group. I want to say this study is probably now 15 years old, but we looked at why patients didn't want to necessarily have their annual wellness exam or didn't want to come in and see their physician. And this was at the beginning of risk adjustment in total. And the feedback that we got, we thought was rather surprising. And that was people didn't want their lives to change, that they associated you finding a condition to now filling up their schedule with doctor's appointments. And how frustrating is that, right? Getting in to see the physician and waiting and things like that. The extra expense that would be associated with that, the medications that might be needed. And so it was more of this ostrich effect, bury your head in the sand. If I don't see it or I don't know about it, then I don't have to deal with it. So I think that's really important. And then I know you and I have talked too that there was a study that was just recently published in 2023 that showed that within a year's time, someone who's asymptomatic will often make it to the point where they're complicated enough that they would now risk adjust under the conditions that are part of the V28 model. And just one final point I'd make to what you're saying and why I think and would agree with you that testing and early diagnosis is so important is that a lot of times we get this tunnel vision, right? Or we look at one point of the work that we're doing. And I think that healthcare has become complicated enough now. We can't just think about risk adjustment. You have to think about quality. You have to think about total cost of care. And so if you're only focused on that one little point within the model that's attributed to risk adjustment, you're not going to be successful in value-based care. You really need to raise the gaze and think about long term. And I know on the day that it was announced that asymptomatic PAD would no longer risk adjust as part of B28, but I want to make sure that folks understand that other diagnoses of PAD would. But I had this group say, we'll just stop all testing. And I'm like, you have got to be out of your mind. That is one of the biggest mistakes I think you could make because you've got to be prepared. You've got to be anticipating of where patients are going. OIG, HHS at National, we're very clear on we have to manage patients. And how can you manage them if you're only looking at one point in time, at that one instance that they're in your office? So you really do need to take a longer view and a longer play at paying attention to your members and managing their chronic condition. So thank you for sharing.
I totally agree. Yeah. And just thinking about like the importance of screening, the importance of screening and trying to get to the bottom of these symptoms. I think back to my dad a couple of years ago. He complained that when I go on the treadmill, my legs are burning. Me being in the peripheral artery disease space, you're like, sounds like you may have a circulation problem. He went into the doctor and it was colon cancer. That was his first marker of colon cancer. And if you think about it, that's one of those cancers that if it goes undetected, you're just going to have worse and worse outcomes. So you're absolutely right. Asymptomatic peripheral artery disease does not currently risk adjust, but it does give you the opportunity to have less invasive, less expensive treatment options that result in a better quality of life. If you think about that asymptomatic patient who maybe has a 20% stenosis in an artery of their leg, that can actually be managed and sometimes reversed with therapies like supervised exercise therapy. Identifying those chronic conditions too can help encourage patients to engage in better behaviors. So, if you have a diabetic who is now experiencing circulation issues, you can use that as encouragement to a patient to say, all right, you now have diabetes and now you're starting to experience some of the complications from diabetes. You really need to think about quitting smoking, eating more healthy, exercising on a regular basis. Now, not every patient is going to be compliant with those lifestyle therapies, but if you're thinking about a patient population of maybe 25,000 folks with peripheral artery disease, think about the impact that you can have down the line. That patient that today has asymptomatic peripheral artery disease, that stenosis is going to get bigger. Then they're going to start having pain during exercise. Supervised exercise therapy may not be the best option in that situation. Now we're talking about a pharma intervention. Continues to go further down the line, we're talking about a therapeutic or a surgical solution that can run $15,000 and up. Yeah. And if it progresses even further, then we're talking about gangrene and amputation. The 2-year cost of an amputation or lower extremity amputation is $91,000. When you factor in the hospital stay, readmittance rates, I know keeping folks out of the hospital is really important, especially for helping them manage the cost of care and the quality of life of your patients. But the lifetime cost has been determined to be $500,000 over the life of that patient. And the mortality rate is very high as well, 33% within 5 years.
Wow, that's
Yeah.
shocking. And again, I know you said it. I'm going to underline it again for folks. the whole thinking around total cost of care. If you're not managing these conditions, exercise is a lot less expensive and less intrusive into the lives of patients. And so thinking about total cost of care as well as patient experience and patient satisfaction, a much better life, happier life, right? Even going back to the point about patients not wanting to know about conditions because it can impact their life negatively. But if there's small changes that they could make now and have positive outcomes or better outcomes, then all the better. Lots of really great information. And I love that you're always sharing that story with us at Rise West and all that important information and presentations that you guys do. But you're active in the community too. And you're out. I know you've been to Washington, which I think is
Yep.
phenomenal. You have some events and some appearances that you're going to make at some local community events coming up. Why don't you tell us about some of that?
Yeah, so great question. Yeah, we are trying to be very active in the community. Yeah, we were invited to a PD caucus event in Washington, D.C. Last year. We were able to test a few Congress people. It just goes back to these stories of folks with diabetes and folks with peripheral artery disease. One of the Congress people that I was talking to, he shared a story with us. He's a diabetic. He definitely had peripheral artery disease. And he shared a story with us. He also has neuropathy. So one day he was walking around his house and it kept clicking when he was walking around. Come to find out, this congressperson had neuropathy so bad he had stepped on his lapel pin and it was stuck in his foot. And he was walking around all day with it and did not realize that there was a pin stuck to the bottom of his foot. We definitely tested him. He definitely had disease. That early detection really goes back to the early detection and getting out in the community. We made a trip to the Mississippi Delta and saw just the impact of peripheral artery disease in some of these underserved communities. We saw a patient she was in her late 30s. So thinking about, I think a lot of the knowledge or the misconception around the disease is it impacts men and it impacts older men. And the fact is, I saw a woman in her late 30s getting a peripheral vascular intervention, and she was in her late 30s. We're starting to see this disease, I think, occur early and earlier in life. I would encourage anyone it's not just impacting males, it impacts females as well. And it's not just the Medicare population. If you're thinking about an Affordable Care Act plan or a commercial plan that is focusing on younger members, screening is not the worst thing to think about.
It's relatively inexpensive and agree. I just gave a talk the other day to another group and we were talking about, actually, I was at a physician dinner and there were probably about 150 physicians in the room. And I asked them, whether or not that I had shared with them some census reports and showed the census in 1980 and then what it is as of 2020. And when you look at it in the 80s, it was like a little picture there where younger people living or the greater part of the population and older folks, not so much. But then if you look at now in 2010, 2020, the census reports, you can see that band begin to widen. And now people are living longer, but they're not necessarily living healthier. And the doctors in the room are like, absolutely. Like they're so busy and they're taking care of so many different chronic conditions. And that's the thing is that patients, again, are living longer, but they're far more complex and it's significantly challenging for sure.
Yeah, that experience of going for a walk or even golfing, even that light exercise, when you think about the impact that has on the quality of life, not only keeping the patient healthier, but also impact on the mental health. We know being outside, being active is good. And there is an association between peripheral artery disease, diabetes, and mental health. I actually thought for a long time that the reason depression and peripheral artery disease were linked was because if someone has depression, they're not going to make good decisions about their health, right? They're gonna eat less healthy. They're going to engage in more risky and dangerous behaviors like smoking or using tobacco. But I was talking to the head of cardiology, and he actually took my thought and spun it on its head, where he was telling me, hey, if a patient has diabetes, if a patient has atherosclerotic disease, it's impacting their blood chemistry and the blood flow to their brains. That impact, that physiologic impact that has on the body can actually lead to other conditions like anxiety and depression. Yeah.
inextricably linked. Wow, that's interesting.
Yeah.
I'm
Yeah.
glad.
That's dude.
Yeah, I'm glad you brought up behavioral health because not that I want to leave PAD anytime soon, because I think we could continue talking about it. We can revisit anything else that you wanted to share. But Biomedics has other screening devices too, and you guys are doing other types of screenings and other services. Can you talk a little bit about that and the other offerings that you guys have?
Yeah, it's a great question. When we launched our new screening device, PadNet Express, it was around the time that COVID just started. We decided to pivot and really fulfill, I think, a long-term plan that we had to be able to combine multiple diagnostic studies around social determinants of health, chronic conditions, and behavioral health, and then have that be contained into a single patient record. That was one part of the vision that we wanted to accomplish. We knew that there are companies out there, there are practices out there. There are different points of care. There could be going into the home, they could be in a nursing home, and moving the data and aggregating the data and determining who's testing who, what is this screening program yielding. We saw that to be valuable. So we found a spirometer. We found a peripheral neuropathy diagnostic devices that diagnose diabetic retinopathy, devices that identify osteoporosis as well. And then we bake some surveys into our platform. So you could, in front of a patient, not only do a peripheral artery disease test, screen them for depression, screen them for personality disorder, do a fall risk assessment, screen them for SDOH, screen them for COPD, peripheral neuropathy, osteoporosis, and diabetic retinopathy all at one time. And then all that data then flows into a single web service platform.
That's pretty amazing to have all that together. I know working with physicians out in the field, very important to them to have something that's simple, that they have it all together, and then they have access to that data. They can import it into their EMR, they can print it off if they want and stick it in the chart. So lots of different options. That's fantastic. All right.
We've been doing screening in clinics and things like that for years. And what we found is clinicians, even if it's a medical assistant, they want to deliver care. They want to be doing the
Right.
testing. They don't want to be moving data from one place to another, entering in data. So we said, what are ways that we can do to streamline that? So a nurse practitioner going into a home, instead of trying to figure out what email address do I send this to, or what person do I call here? They got a single point of contact for customer service. They got a single space where all that data flows into, and they don't have to do any copying and pasting and emailing and putting something into a Dropbox, worrying about whether it's secure or not. We handle all that in the back end so they can focus on the patient.
So what happens though if you meet an office and say they're interested in PadNet Express, but they have other devices already? Are you able to incorporate those into the platform?
Absolutely. We're compatible with not every COPD device and not every peripheral neuropathy device. So if it is a device that's compatible with our platform, then we can certainly plug that in. We have a customer service department, and we've really differentiated ourselves from other medical device manufacturers in that we package our products and services as a single solution. So instead of selling a box and maybe doing a quick training and then hoping they never call us back, we actively engage with our customers and aim to be strategic partners with our customers rather than thanks for the purchase and I hope I never talk to you again.
I can tell you as someone who has launched many of those programs over the years in different parts of the country, as part of I was managing risk for IPAs. We would encourage our physicians to do different screenings, and it might be for peripheral vascular disease, it might be for neuropathy or COPD, and a variety of different devices. But one of the things that I found was really important, which was exactly what you said, that there were a lot of docs that would have devices in boxes and they were never hooked up. And so we spent the time going through and teaching them and their office staff how to use the equipment. We set it up for them. We had a really great partnership in making sure that they were using the device, and we gave it to them to use, but it was based on, we know you have this panel. We know that there's typically a certain prevalence of disease. We can go out and look at the CDC, what the rates are. We would expect,
Yep.
looking at your panel, that you would test these individuals. So I just want to see something that's commensurate with your panel mix, that you're demonstrating that you're using the device. And we would monitor the usage. And we could tell if maybe Mary Jo left or was on vacation and all of a sudden we weren't seeing tests come through. We knew it was an opportunity to go out and do education, or that they were now lacking supplies. And so we had to get them different things to be able to use our equipment. So I think that, that's really important, that it's not enough to just hand someone the box and say, go use it. You need to really have the wraparound operations. And I love the idea of the one stop and being able to look at the testing and the results and get all the analytics and the feedback, as well as being able to see what their usage has been and whether or not there's opportunities for training. So that's fantastic.
Yeah, and it actually goes beyond usage. We had a customer and we were doing some analysis with this customer, and we found there was a user who was doing a peripheral artery disease test, but they were only doing one side of the body.
Wow.
We thought was strange. Our device can, so if a patient has an above the knee amputation and you can only really screen one side of the body, we can certainly enable that. And that is possible within the software. But this user was only doing one side of the body each and every time.
Wow.
We contacted that user and we found out that a peripheral neuropathy screening device, typically what they do is they only screen one side of the body. So that technologist or that nurse practitioner thought that it's the same thing for peripheral artery disease. So we had that opportunity to reach out to them and educate them. No, you actually need to test both sides of the body for this test. And that's going to result in better clinical outcomes and a better, more accurate capture rate of the disease.
I can't even, I love that story. And I'll share a couple too, because I would
Yeah.
absolutely agree. People would be surprised. I can remember hosting one of those education sessions, and a physician came with their, I think it was or office manager or someone from the office, and they brought one of the devices and they said it doesn't work. And they couldn't figure out why it didn't work. And they simply had put in the battery wrong. Or incidents where a device required certain products to be used. In this instance, they needed a transducer gel. I don't know if I'm saying that, but they used too much. So little things like that. So a lot of times we make assumptions that, again, everybody's going to know. And I don't know, anyone who's never has kids and have had to put together things at Christmas time with the instruction, it can be pretty hard. And sometimes you just throw your hands up in the air. I'd like to venture to say that probably the same occurs in our physician offices across the country, just because they're busy, and for someone to sit and figure those things out, or sometimes things are missed, like the idea of the one side of the body. They're applying knowledge from something else, thinking that it would be applicable, but it's not really important.
Oh, yeah,
I want
exactly.
to go. I want to go back, if it's okay, because we didn't get to talk
Oh,
about
yeah.
all the events that you guys are doing, and I know that you're going to be, I think, the Minnesota State Fair. Why don't you tell us a little bit about that, what you have planned?
Yeah. So we were actually at the state fair. There's a Driven to Discover a research barn at the University of Minnesota's their location within the Minnesota State Fair. And the Minnesota State Fair is, I'd say, one of the bigger national fairs. So it's a big deal in
Great.
Minnesota. We in the past have worked directly with the University of Minnesota on some research projects. And last year we worked with Boston Scientific to do some screening of their employees and to help raise awareness of peripheral artery disease. Boston Scientific worked with the University of Minnesota, and they're going to be collaborating with us as well. So we're going to have a stall in quote unquote this barn, this Driven to Discover barn, and we're going to offer free screenings for peripheral artery disease. When we were there a couple of years ago, we were only there for one day, and there was a line outside of the booth. People were just
Wow.
waiting to get tested, and we were using some University of Minnesota medical school students. It was amazing to see our device and just how quickly people could use it. We would have shift changes, and they'd come and ask me, hey, I'm ready to, my shift is starting. Can you show me how to use this device? And I would sit them in front of a patient, and their training would be while they're actually testing a patient. And they, after one test, they were ready to go. Once in a while, they had questions and things like that. And that goes back to the training that we offer too. It's not just that initial training, but sometimes 6 months later, they may need another training. I'm excited about that opportunity. We'll be there on 2 days, August 27th and August 29th. One is a kind of a Veterans Day, and then the other day is focused on senior citizens. Really excited to hopefully engage with some veterans out there too. We know that diabetes in veteran populations is overrepresented too. So hopefully we can help raise awareness of this disease so they can go back and talk to their doctors if they're experiencing pain while they're walking or while they're resting, rather than just dealing with the pain without reporting that.
Do you share with them the printout if you find that someone is suspect for peripheral artery disease? Do you share with them the screening report that they can take that back to their physician?
I No, we actually do. Yep. Oftentimes it's not a doctor doing the test. I'm not qualified to deliver a diagnosis. And I'm always very careful to say that. And we train all of the users to say that as well. But we do give them the report. And that report typically includes things that you can do to help address or prevent this from happening to you. Some of the lifestyle modifications we talked about. And then also saying, hey, if it does start hurting when you're walking or your legs start hurting, make sure to talk about that to your doctor and feel free to share this report with your doctor.
I think that's great. Great advice. And again, just want to harken back to what you said earlier that leg pain isn't necessarily a sign of old age. A lot of people attribute it to that, but it could be something else that is underlying it, causing that.
Yeah, I think any sort of risk bearing or delegated medical group that's taking on risk in a capitated arrangement, especially if they are experiencing downside risk, I think could definitely benefit from a PAD screening program or helping to identify those chronic conditions. I think when you think about primary care physicians, they're doing a blood panel. I just went in for my wellness visit. I didn't see a spirometer there. I didn't see some of the other diagnostic tools we have out there. So is there an opportunity to engage primary care physicians? And I think if they're operating in a fee for service capacity too, a lot of these physicians are being faced with declining physician revenues. The physician's fee schedule comes out every year. And I think they're continuing to get this downward pressure on the physician fee schedule as we're trying to contain healthcare costs. I think if you think about a patient who is at risk and you're having to manage that on a capitated basis and you need to control the cost of care, identifying chronic conditions is definitely important. The other thing to keep in mind is if you're working with a patient in a fee for service capacity, these are reimbursable tests. So a physician who may just be billing E&M codes and they see that those E&M code reimbursements continue to go down or don't keep up with the pace of inflation, they have these physician extender programs. A physician doesn't need to do a peripheral artery disease test. A physician doesn't need to do a spirometry test. The devices that we picked out are supposed to be easy enough to be used by a medical assistant. And we found that when we were screening at the state fair, a med school student can walk up and start testing for PAD immediately. So as long as they're under the general supervision of that doctor, you can leverage the staff and the space in your clinic to help make your practice more financially sustainable through fair reimbursement of these physician extender programs.
I think all really great points, and there's a lot to unpack there and can share just working in physician offices and with physician offices, preparing ones again across the country. That was one of the things that we would make recommendation for was how could you lean on other members of your staff that could help you do that work and do that testing. And we would work with the MAs, we would work with the nurse practitioners and others in the office to do the various screenings so that when the physician entered the room, they had all that information available to them so that they could see the patient. So I think that's so important. And then the other thing you mentioned, and I want to be careful because I think sometimes folks think, oh, we run these tests just to make money. And it's not about that, right? It's not about, and again, it goes back to what we talked about earlier about raising the gains. It's not this one to one that I did this test and now there's this fee. It's not about that. We really need to think about it as we do this screening to keep people healthier because the more complicated someone becomes, the more time that they require. I don't know that the physician fee schedule, I know that there's different layers or levels of complexity built in, but probably not commensurate with the time that you're spending. And so again, ideally raising the gains, if you can keep that patient healthier for longer and less complicated, because you've done these screenings and then you've implemented or done other types of therapies and treatment to keep them in the earlier stages of that disease progression, then all the better. And so again, I think it's really important. And just one other thing I'll share. I know that the model has changed, but I know that when we implemented peripheral vascular screening, and I can even, if anyone's interested, I'd be happy to share and demonstrate just the improvement in better capturing or getting to the prevalence rate on any particular conditions that we screened for, be it COPD, vascular disease. We found that it was about not only did we better match prevalence rates, but even just on vascular disease alone, it was about a 9-to-1 return. So when folks think, oh, those devices are expensive, not really. It's a small investment. And to your point earlier that you mentioned, you think about what a test cost and then compare that to the cost of one of those conditions being $500,000. It's really easy to see that it makes sense to incorporate that and to include that into your workflow, into the primary care workflow. So really important.
Yeah, I definitely agree. Yeah. And I think it's important to know. I think there's this misconception that identifying peripheral artery disease, they're going to have to see a specialist. Now they're going to have an expensive therapeutic intervention. That not necessarily doesn't have to be the case. I think there's education. There's more, you could probably monitor that patient on a more frequent basis, but we are really committed to ideally preventing that surgical intervention from having to happen. And I know I talk to interventional cardiologists and interventional radiologists, and they're always seeing the non-compliant patients. But I think there is a real opportunity to reduce just how many patients have to have an amputation, reduce how many patients have to get a balloon angioplasty or an atherectomy by identifying this disease earlier. These technologies are great. They're also expensive and they're not ideal. Having stuff in your body really isn't the natural way to live your life. That's why I'm hoping that this identifying these chronic conditions can result in this behavior modification.
Would absolutely agree. And I know when we first introduced early screening uh, to our physicians in some different offices that I was associated with, that was a concern that they were going to have to order this expensive testing. And that was the things that you still treated it the same way. It was asymptomatic, but you had an opportunity to potentially introduce these other opportunities, like you said, for diet and exercise and to use other types of therapies that were less expensive. And then also, too, would have better impact, right? Overall on that patient. And I know I mentioned earlier about people living longer, but not necessarily healthier. Would agree with you too that we are seeing higher and higher propensity for younger people to have these diseases as well and developing them much younger. And I know we were advocating screening even to as low or as young as 45, possibly even younger based on their lifestyle, whether they were smokers and a history of disease and those types of things. But we were testing individuals as low as 45. Again, just to be aware. And if there was an opportunity to introduce an intervention that would be successful, that we would do that. And that would be important.
Yeah, I think one of the big misses I had at the beginning of my tenure here at Biomedix was we focused a lot on, we talk about risk adjustment and the impact that has financially. We talk about the CPT codes and the reimbursement per test that you can get. I was at a physician education event in front of, I'd say, about 150 doctors, going through the things that I typically would go through, talking about reimbursement rates and things like that. But I introduced some new material that was focused on reducing the cost of healthcare. And I saw the mood in the room shift. These doctors really started listening. Eyes were opened. And that's where I got the majority of my questions. So I think if you think about educating your doctors and your practitioners, co-opting this cause of reducing the cost of healthcare, I think is something that doctors want to be engaged with. It's something that they want to do. We know that healthcare costs are higher in the United States, and we have less optimal outcomes than other countries that spend much less money. So I think these doctors, they aren't just in it to make money. They are committed to this cause of reducing the cost of healthcare. And if you can show them different ways that they can do that, they'll listen. They'll change their behaviors. They'll get enthusiastic about it.
Fully agree. Any physician that I've ever spoken to, really, at least what's been communicated to me is that they went to school because they wanted to help people. That's always been the motivation. And I think they want to be respected and they want to be used to the top of the license, really making a difference and being able to help people. So would absolutely agree with you.
I think the larger medical community is starting to open their eyes to the impact
Yeah.
that peripheral artery disease has. The American Diabetes Association just issued a statement. They're strongly recommending peripheral artery disease screening for diabetic populations.
So you were talking about cost earlier, and I think that's really important. We were talking about how physicians aren't necessarily in it for the money. They went to medical school because they wanted to help people. Obviously, we don't expect anyone to be a martyr. People should be paid for the services and the contributions that they make, and it should be commensurate with the level of skill that they bring and the investment that they've put in. But I would agree with you on the cost, and it's really easy to figure out. I know I've done it for COPD. I've done it for peripheral vascular disease. I've done it for CKD. Really easy. Go look at what the prevalence is. You can go to the CDC, pull out what the prevalence rates are for a particular age group and population, and then look at what the typical costs are associated with it. You might have to look at, say, what the inpatient stay rate is and those types of things. And you know what the average cost is for a day in the hospital. So it's really easy to calculate very quickly how much something costs. And then you compare that. You have folks that, and I know early on in my career, I would have folks that would say to me, oh, risk adjustment, it's an administrative burden and it's about the money. And it's not. But it's about staying whole. And when you look at the cost, the reimbursement is nowhere near what the costs are associated. And I think that just going back to what we were saying earlier is that you can't disconnect risk from total cost of care from quality, that we really need to look at healthcare as this whole system. And again, I would agree with you that if you look at what the costs are associated with these conditions that you guys are able to screen for and be able to get that data on, it's so important when you think about what any reimbursement value or anything like that can be. And that's at a minimum, right? When we're looking at risk reimbursement, it's contingent on you making sure that you capture every diagnosis in the population. And we know that we're not able to do that. So I think that the better strategy is to focus on, not that risk isn't important and quality too, but to also focus on total cost of care. I think that there's a missed opportunity there for sure, or at least one that we're
Yeah, I
not
mean,
effectuating.
definitely. And you think about the stories around risk adjustment and what's projected as being a big money grab. I think the payers need to, the folks that are doing the risk adjustment need to demonstrate that, hey, now that you've incented me to identify and get a better view of my patient population and I can deliver better care. That's really the vision of risk adjustment and the reason for the Medicare Advantage program in the first place. Not any incentive program, there's going to be some level of fraud and abuse, right? But a good payer and a good community can say, hey, you know what? For a long time, these chronic conditions were underdiagnosed. We have a more complete picture of these patients. We're delivering better care. So really delivering on the promise of the program is something that we're hoping to help with in the next 5 years. And I think that is something for the risk adjustment community to shoot for too.
Agree.
We talk about this lack of therapy, right? Delivered with these risk adjustment codes. I think the fact of the matter is we're just not doing a good job of connecting the HCC code to the actual therapy being delivered. And sometimes that's hard to see when you're looking through a swath of charts to tie an ICD-10 code to a CPT code associated with therapy and documenting that properly.
Yeah, wholeheartedly agree. And you made me think too, in talking about risk adjustment, I want to make sure too that our audience pays attention to, even though we may be thinking quite a bit about Medicare Advantage, that this is applicable to all risk bearing arrangements. And so there's lots of other programs out there. We know that CMS has said that they expect to have everyone in a risk bearing arrangement by 2030. That doesn't mean that everyone's going to be in Medicare Advantage, right? So you have Medicaid, you have ACOs, there's other types of risk bearing and risk sharing arrangements out there. There's opportunities to develop other types of structures in benefit offerings at health plans. And so just wanting to make sure that folks are thinking about that as well. What about you? What types of trends are you seeing? Are you hearing anything out there? Maybe what types of organizations that you're working with that to help me justify the hypothesis that it's not just, or at least my thinking that it's not just Medicare Advantage, but that other groups are interested, should be interested and are thinking about other ways to bring this type of program into
Yeah, it's a
your
great.
offerings.
Yeah, yeah. We, for a long time, obviously focused on the Medicare Advantage space, but we are starting to see interest in ACOs, accountable care organizations, and then also the PACE program. I think that's an interesting program. It's very popular. It's one of those programs where knowing the status of your patients is really important. Really excited to start seeing, are there opportunities in some of these other spaces, because we're getting interest even though we're not necessarily reaching out. They're reaching out to us. They're understanding, I think, the value proposition that we bring to the table. For a long time, we've talked about going through charts, analyzing data, going through claims data, but doing this prospective physiologic testing on patients can offer a real return. Not everyone goes to a physician who's really good at documenting ICD-10 codes, or who is, you think about, sometimes some doctors, they're reacting to a problem. They're not doing health management. They're not trying to prevent issues from happening. They're managing problems as they pop up. So
It,
this helps us create that calculus, right?
absolutely. There needs to be a paradigm shift, no longer being reactive, but rather being proactive. And I think that the services and the offerings and just the awareness that you're helping bring to the community is really important. So we've talked about a lot today. We've spent a lot of time talking about PAD, which I think was really important. We also had an opportunity to talk about the other types of devices that Biomedix has available, as well as your exchange platform. And then
Yeah.
a lot of the different community events and awareness events that you're involved in. Is there anything else that you were hoping to share with us today that maybe we didn't get to?
Well, no, not that I can think of. I think opportunities we're looking at exploring with some of our customers are, if a patient has cardiovascular disease, whether it's peripheral artery disease or some other condition, they qualify for a CSNP program. Are there things that we can do to help a Medicare Advantage or a payer organization to optimize their population? Maybe they set up a CSNP program. Maybe they're putting those appropriate patients in that CSNP program, and then they have appropriate funding to help manage those chronic conditions.
Again, excellent point. I think, and would agree with you too, just with all the complexities, we know human beings are complex, right? And so I know you mentioned social determinants of health, and I think all of those components come together in order to deliver the same level of individual or personalization. I think that's necessary and that people have come to expect. They expect it from healthcare too. And in order to be able to do that, we need to have benefits and plans that are tailored exactly to what people need. And putting everyone together and thinking that one plan is going to serve all, I think is foolhardy, especially given a lot of the changes. I have one final question for you. Are you ready?
Sure. Yeah.
I'm
Yeah.
curious. I know you're out there, you're working with lots of different groups, and you've got the beat on the street, being at these various conferences. What do you see as being the biggest challenge in healthcare 5 years from now? And how are you hoping that you can help customers solve for it?
Yeah. So one of the things that just got released is there's an estimate that by 2030, 60% of the US population is going to have cardiovascular disease.
Wow.
So we know that cardiovascular disease, we talked about PAD today, but are there opportunities to identify other types of cardiovascular disease? Most likely have this North Star to figure out, is there a way to detect other cardiovascular disease, whether it's using our device, other devices, but what's fast, what's quick, what's easy, what can help our customers identify, maybe it's not just peripheral artery disease, but it's coronary artery disease or it's carotid artery disease. And how do we develop devices and technologies that are easy enough to use where you're not having to go to a vascular lab, you're not having to go see a cardiologist in order to have these studies be done. So that's I think a big challenge is this incidence of cardiovascular disease and detecting that early and addressing that before the patient has a heart attack and has to go to the hospital, or the patient has a black toe and that needs to be amputated, or they have a stroke. That is our North Star is, what are some other cardiovascular conditions we can work with our customers to help identify without it being too burdensome. We know that these physician practices are busy. Labor is not cheap. So how do we help them identify and get a more clear picture of those patient populations, especially around
Right.
cardiovascular disease. Yeah.
No, I think that's an excellent contribution, and I didn't know that, and I am guessing that a lot of folks might not either, and so I think that's a very eye-opening statistic and one that we need to pay attention to, especially thinking about all the other things going on in healthcare and all the legislative changes and other things that we're trying to deal with, that we might be thinking about the administrative functions and pieces that we need to manage. But the real point of it all is the patient and taking care of them and knowing that cardiovascular disease is going to be so prevalent, not just taking care of patients and keeping them central, but our physicians too. And definitely think that screening and the other types of things that you guys offer will help do that. So thank you.
Yeah, exactly. Yeah.
Yeah. Chris, it's been great chatting with you today. I've had a lot of fun. I definitely learned a lot. Always great getting to talk with you. And hopefully, our listeners will be able to make it out to a conference in the circuit there sometime soon and get to visit with you guys. But if not, I know that they can reach out to you probably on LinkedIn or through Biomedix
Yep.
website too if they want to learn more. Great. Thank you so
Yeah,
much.
definitely. We'll be at the risk adjustment conference in Louisville in November too. So
Awesome.
look forward to
Right.
that.
This risk
Yeah.
adjustment forum. Perfect.